Welcome back to Physio Vibes. In this video we are going to look at
Peri Arthritis shoulder and physiotherapy management.
Before we start, hit the subscribe button for more videos. Press the bell icon and never miss another update.
Peri Arthritis shoulder and physiotherapy management. It presents with gradual painful restriction of all the movements of the shoulder. It is thought to be due to an inflammatory degeneration of the shoulder joint capsule and the soft tissue surrounding it, resulting in adhesions. Dupley first described it in 1872 and called it as humeroscapular arthritis. In 1934, Codeman coined the term frozen shoulder, and in 1945, Novissa gave the name adhesive capsulitis. It is also known as adhesive capsulitis and frozen shoulder, also referred to as the shoulder of 50s, because the condition is very common around that age. The causes for frozen shoulder could be primary. Here the exact cause is not known and it could be idiopathic. Secondary. According to Lumberg, the secondary causes could be problems directly related to shoulder joint which can give rise to frozen shoulder are tendinitis of rotator cuff, bicipital tendinitis, fractures and dislocations around the shoulder, etc. Problems not related to shoulder joint like diabetes, cardiovascular diseases with referred pain to the shoulder, which keeps the joint immobile, reflex sympathetic dystrophy, a complication of Cole's fracture, can all lead to frozen shoulder. Pathology. During abduction and repeated overhead activities of the shoulder, long head of biceps and rotator cuff undergo repeated strain. This results in inflammation, fibrosis and consequent thickening of the shoulder capsule, which results in loss of movements. If the movements are continued, then the fibrosis gradually breaks, movements return but never come back to normal. Clinical features. It produces pain and stiffness of the shoulder. In early stages, the pain is worst at night, and the stiffness limited to abduction and internal rotation of the shoulder. Later, the pain is present at all times and all the movements of the shoulder are severely limited. The patient demonstrates a capsular pattern of movement restrictions. Tenderness all round the shoulder with more than one tender spot. Accessory joint play is reduced. Patient is unable to do routine daily activities like combing the hair, in case of women wearing the buttons of their blouse doing overhead activities, etc. Diagnosis. Diagnosis is mainly clinical. Radiographs are mostly normal. MRI may show thickening in the area of rotator interval. Physiotherapy management. The disease is self-limiting with a chronic course that spans over a period of 6-12 months, passing through 3 characteristic phases. Stage 1. Painful phase, few weeks to months, and SEDS, intra-articular steroids. Stage 2. Phase of progressive stiffness/freezing phase, 4-12 months. Stage 3. Resolution/thawing phase, few weeks to months. For stage 2 and 3 person have stiff shoulder, it needs following physiotherapy measures. Thermotherapy is given before to passive mobilization. The thick contracted capsule gets relaxed. Passive mobilization of shoulder joint by the therapist in a forward stooping position. Passive gliding antero-posterior adduction abduction glides of the shoulder joint with longitudinal traction. Active rhythmic pendulum exercises for shoulder mobilization. Shoulder wheel exercises to be done at the physiotherapy center. Pulley exercises can be done by the patient himself at home. Wall climbing exercises by the arm can be practiced at home.
Thanks for watching. Don't forget like, share and subscribe.